long case. As I already started the scenario before, it's basically a case of a cardiac arrest. Patient 55-year-old male was found unresponsive in a lake after collapsing while swimming in a sub-zero temperature, with cardiac arrest being unwitnessed. Bystanders initiated CPR and paramedics brought patient to the hospital ER with ongoing CPR. Dr. Soumya, are you ready?
Yes, sir.
1 minute, I am not able to hear you properly.
Hello.
Are you ready, Soumya?
Yes, sir. Can you hear me?
Yeah, I can hear you.
Okay.
What are the cause of cardiac arrest in this patient?
Probably my differentials are a massive myocardial infarction, that is acute coronary syndrome. Second possibility is that he could have had a hypoglycemia and fallen into the sub-zero temperature lake. Any arrhythmias, a seizure, possibility of massive pulmonary embolism,
Yes.
any dissecting aortic aneurysms, or a stroke, possibility of drug overdose or an alcohol intoxication.
Okay.
And if I have to include other 5H and 5Ts.
Okay.
Like any electrolytes like hyperkalemia, hypothermia, more so because he was swimming in a sub-zero temperature.
Okay.
Any tamponade or a tension pneumothorax.
Yes.
Any thrombosis, like I already included, massive PE and NMI.
Yes. See, what is the cause of cardiac arrest? Always you put 5H and 5T so that you don't forget anything. In this scenario, since there's very specifically, it's mentioned that it's a sub-zero temperature, and this case scenario has come in the exams. Okay. So whenever there's a patient has sub-zero temperature, first always consideration is primary hypothermia. Then comes your drowning. Then it can be a head injury per se. They might have tried to dive in the water. Okay, as you told, other cause like toxicological cause, it can be alcohol or drug overdose. It can be ACS, it can be stroke, it can be seizures, or it can be any metabolic disorders, including hypoglycemia and hypothermia. Okay. The few things expected in the exam is hypothermia I have to mention. Since there is a swimming I mentioned, I have to mention drowning also. There are a few things which are specific to these cases.
Okay.
Okay. So always mention 5H and 5Ts. Even if you forget something, it will be automatically included so that you won't forget.
Yes.
Okay. So how will you manage this patient?
A patient is brought to the ER by the bystanders giving a CPR. I see that patients, when I get the, will take over.
1 minute. Okay, can go ahead now.
We'll take over in the ER and continue CPR. Meanwhile, I'll take history from the bystanders. And with this history of sub-zero temperature and collapse near the lake, with the clothes all being wet, probably I'll continue CPR, take out all the wet clothes and start warming the patient with at least the available warm blankets and passive rewarming basically initially. And then I would start him off with active, at least warm IV fluids and warmers. And here, because it is a hypothermic cardiac arrest, I would like to continue only the CPR because the effect of adrenaline in a hypothermia, it may not work. So I would like to continue him with the CPR. And then once the temperatures at least reach above 30 degrees, I will continue to give him adrenaline, almost the double the dose. That's what the ACLS recommend. And anyway, he's in the sub-zero temperature, so my targeted temperature management also might come into play here. I would like to rewarm him up to 34 degrees.
Okay.
And then consider other causes while doing the resuscitation. I would like to rule out other causes of cardiac arrest, like more so the pneumothorax and rest of the.
Okay.
Yes.
Okay. Is there any active rewarming measures you are aware of?
I would like to give him warm IV fluids and bladder irrigation with warm fluids and bear hugger. And if nothing works out, the last would be ECMO.
Okay, correct. Okay. With related to defibrillation, anything specific in hypothermia?
I think the defibrillation, this may not work, so I
Yes.
would to continue only the CPR, sir, initially.
So they say that less than 30 degrees, your defibrillation success is very low, so there's no
Yes.
point in doing it. So when it reaches more than 30, you can consider giving defibrillation for
Defibrillation.
VF and VT.
Yes.
Okay, there's some HA is the one thing is HA is not sure about that or medication intervals and all, but you can say that they say that you can give at a prolonged intervals when the temperature is low. Once it reaches more than 35, you can give it a regular dose.
Yes.
Okay. So in the meantime, you'll be doing the intubation, ventilation, all those things you'll be doing in this patient.
Yes.
Okay. So this patient, we have done all these things. One is ongoing CPR. In the meantime, warming. Initially, external rewarming. If the patient continues at a low temperature, you can consider putting an ECMO or cardiopulmonary bypass for rewarming.
Yes.
Okay. So next is this patient was CPR was continued. ROSC achieved after continuous CPR. Patient was intubated and ventilated. Then the vitals they noted was heart rate was 30 beats per minute, BP was 90/60, saturation 96 with FI out of 80%, PEEP of 8, respiratory rate of 24, GCS is still E1 VTM1, pupils bilateral equal and reacting to light, ear entry is equal, some creps are noted, GBS was 180, pH is 7.2, P out of 96, PC out of 42, bicarb of 16, lactate of 4.2. Okay. So what are the findings in this? What are the findings, abnormal findings in this?
So patient has symptomatic bradycardia.
Mm.
He is hypoxemic on and his GCS is poor, and ABG is showing metabolic acidosis with lactic acidosis, metabolic plus respiratory acidosis with lactic acidosis.
Okay. The other low GCS is
Yes.
also there.
Yes.
Okay.
Yes.
So next thing is they've done an X-ray for this patient. Okay. So X-ray, it looks like this. Can you interpret this X-ray?
So this X-ray is showing diffuse GGOs.
GGOs. GGOs is a finding of X-ray or CT?
I know. Actually, my diffuse haziness, probably because of the drowning, would be an ARDS, and also there are multiple. There is ECG leads. Along with that, there is a Riles tube, and yeah. And an ET tube. This is not very clear about the ET tube. Not very clear about the ET tube.
See, one interpretation mentioned that bilateral diffuse heterogeneous infiltrates all over the lung zones. Okay.
Yes.
With ET tube in situ and NG tube also. If they ask what is the differential, you'll be saying ARDS, aspiration pneumonia, drowning, all these are your differentials.
Yes.
Okay. How will you manage this patient with ARDS?
So now I would like to shift the patient to the ICU. Before that, I would like to get the basic investigations like complete hemogram, renal function test, electrolytes, a
Well,
GRBS.
first you say from the ADS perspective,
Okay.
ventilation perspective, then we'll go to the further. I'll give some more investigation.
Yes, sir. Yes, sir.
Okay.
So I would like to shift this patient to the ICU. Since already he's in ARDS, so I would like to sedate and paralyze him and get an invasive lines, central line and an arterial line, and monitor his ABGs frequently with sedation paralysis if he's and a PEEP of optimal PEEP. If his PF ratios are not improving, then I would like to go ahead with the prone ventilation with the lung protective ventilation strategies.
Okay.
If despite of that the PF ratios are not improving, then I would like to consider ECMO based on either VV or VA ECMO based on his hemodynamics.
Okay. See, so I discussed with you before also.
Yes.
Basically, they've built up a scenario to give an ARDS now. Okay. So how will you answer in the exam? What is expected in a ARDS ventilation per se? So when exam it comes, no, it should be automatic answers.
Yes.
Now I'll continue with the low tidal volume, 6 ml per kg, with moderate to high PEEP based on the oxygenation. If severe ARDS, I'll go for a moderate to high PEEP. Limit plateau pressure to less than 30 centimeters. Driving pressure less than 15 centimeters. If patient is refractory hypoxemia, I'll consider prone ventilation also. Next upcoming thing is mechanical power that may or may not expect. Minimize ventilator settings, that's what it's supposed to do. Okay. Then I'll consider prone ventilation, recruitment. Recruitment is now no role. Now I'll not say that recruitment. ECMO and refractory hypoxemia, these are ventilator measures. So from the fluid management perspective, I'll try to maintain neutral or negative balance. Sedation and paralysis for 48 hours. So these are the things which are expected in the exam. Okay. So whenever ARDS, invariably ARDS will come in one or two scenarios in the exam.
Yes.
Okay.
Yes.
Either directly or indirectly. Okay. Whenever it comes, you see this answer without thinking. You literally by heart this. I told you there are certain things you have to by heart in the exam. This one, TBI, sepsis, these are things you are going to by heart because it comes again and again in one or the other form.
Yes, sir.
Okay. So I'll in this patient. Okay. So now you tell me. I just deviated a little bit to just to finish ARDS.
Okay,
Now
sir.
tell me how will you approach this patient now with that chest X-ray with that all this picture and all.
Okay. So I would
perspective first and then management.
Sorry, sir.
Investigation perspective first.
Okay. Okay, so I would like to send basic investigations with CBC, renal function tests, and electrolytes to look at, because he has symptomatic bradycardia, I would like to look at the potassium, calcium, magnesium, and a chest X-ray, and a CT brain, basically, and to look for any to rule out any ischemic or a hemorrhagic stroke, or an SAH, and post that I would like to shift the patient to the ICU for further management. Okay. And in the ICU, I would like to secure invasive lines because he is hemodynamically unstable plus in ARDS. Secure invasive lines and update the family also about the same. And before that, I would like to do an ECG also to rule out cause for cardiac arrest, thrombosis.
Along with ECG, anything else you would like to do?
ECG, echo. ECG and an echo.
Okay, whatever you say, don't say. ECG echo is mandatory along with TROPI.
TROPI 12, yes.
Other things, investigation you're doing as a part of the routine management. This is the ECG. Can you interpret this ECG?
There is ST elevations in 2-3 AVF with 2-3 AVF and V5-6. V6 and sinus brady with the looks like a complete heart block, sir. There is dissociation, AV dissociation.
Okay. This actually, as you told, it's infraval STEMI with a complete heart block.
Yes.
Okay. How will you manage this patient now?
I would like to alert the cath lab and the cardiologist on call. And meanwhile, I would like to give loading doses of antiplatelets, aspirin 325 milligrams, ticagrelol 180 milligrams, and an atorvastatin of 80 milligrams, and shift the patient to the cath lab for reperfusion for a PCI, emergency PCI.
Okay. Bradycardia, sir, you would like to do anything for bradycardia?
Initially, yes, sir. So I would like to give. He has a symptomatic bradycardia. So I would like to give fluid boluses. Along with that, I would like to give an atropine, 0.6 milligram to a maximum dose of 3 milligrams. If it doesn't respond to that, I would like to start him on adrenaline infusion until the patient is shifted to the coronary unit. And also would keep pacemaker at least the temporary transcutaneous pacing ready until the patient is shifted to the cath lab.
Okay. So, as you told already, so bradycardia management. So you'll be giving atropine, but generally the atropine may not be effective in these patients. First and most important thing is reperfusion strategy in this patient.
Yes.
Okay.
Yes.
So other things you told, you mentioned cardiology opinion, right?
Yes, sir. In fact.
So next patient admitted CAG. CAG showed double vessel disease affecting both RCA and L6. RCA was 90%, L6 was 70% block. Lesion characteristic, significant stenosis with both arteries, the RCA lesion being a likely culprit based on a clinical presentation of inferior STEMI. So now, what is your plan of action for that?
So I would like to go ahead with the primary PCI to the RCA culprit vessel. Would consider stage PCI to the LCX. This and post that I might consider based on his LV functions and thrombus burden. Would like to consider discussing about the IABP as well if needed. Would like to consider that and shift the patient to the IC.
Okay, fine. See, in exam, no, generally this question will come maybe in the setting of triple vessel disease or something like that. But always you say is to be on the safer side, you basis will take a multi-team opinion. It's a hard team involving interventional cardiologist and a cardiothoracic surgeon. So generally the evidence is you'll be treating culprit lesion only, especially in case of STEMI. You'll not be treating non-culprit lesion in STEMI. Okay, that's what you have to convey.
Yes.
Okay, always say multi-disciplinary heart team opinion will be taken, which involves an interventional cardiologist and a cardiothoracic surgeon. Okay, patient underwent angioplasty with regulating shunt to RCA. Patient was continued on DAPT. Post-angioplasty, ST changes resolved with the resolution of bradycardia. Post-procedure or day 1, patient has noted to have a worsening AK with creatinine of 1.7, 125, total counts of 25,000, platelet 2 lakh, neutrophil 74, lymphocytes 10, eosinophil 10, monocytes 4, lactates of 2. Okay, then this findings are noted in like. Can you tell me the differentials for this and why?
Sir, probably cholesterol embolism.
Okay.
And could be vasculitis. Could be fulminant sepsis-induced purpura.
Okay.
And
Okay, that's good enough. Why you say cholesterol embolism? Can you justify your answer?
Sir, he is. This looks more likely a type 1 MI, where there could be a plaque rupture and erosion, thrombus formation. So probably that could have led to this embolism.
Any parameters, anything which might point towards cholesterol embolism syndrome? AK is there along with there's a eosinophil predominant neutral.
Yes, sir. Eosinophil.
That might point towards your cholesterol embolism.
Yes.
As you said, it might be all of this, but most common diagnosis will be in this case cholesterol embolism syndrome.
Yes.
Okay. Fourth procedure on day 3, patient developed hypoxemia with hypertension. Okay, and in the examination, patient is on ventilator on PRVC mode. Saturation is 88% on FIT of 70, heart rate 125, BP of 80/50. On systemic examination, bibasal Krebs says that JVP is elevated.
Okay.
Okay, what are your differentials for this?
An acute.
Just show them.
Yes. Acute pulmonary edema, probably secondary to any mechanical complications like mitral regurgitation. Second,
what are the mechanical complications you see?
Free wall rupture, ventricular septal rupture, any mitral regurgitation due to the chordae rupture.
1 minute, so
Yes, tamponade. Hello?
1 minute. I think my internet is slow. Just give me a minute. Can
Yes,
you hear
sir,
me
yes,
now?
sir. So,
can you tell me
yes.
the complication,
So
mechanical complication again? Sorry, I
yes,
couldn't
sir.
hear you.
So acquired ventricular septal rupture, free wall rupture, any mitral regurgitation because of the chordae rupture, tamponade. Yeah. So these are the mechanical complications. Hello?
1 minute. Some internet problem is there.
Yes.
I'll just sort it.
Yes.
Okay. Now go ahead.
The mechanical complications I would expect are acquired ventricular septal rupture, free wall rupture, acute MR because of the chordae rupture, a tamponade leading on to cardiogenic shock.
Okay. Okay. Stent thrombosis, did you consider?
Yes, sir. Yes, sir.
Okay, stent thrombosis. Other one is it can be just acute heart failure due to LV dysfunction.
Acute heart failure. Yes, sir.
Okay, these are the complications you're going to expect in this patient, especially day 3 to day 5.
Okay.
Okay, investigations were done. What are the investigations you would like to do for this patient?
I would like to do an ECG, an echocardiogram, a chest X-ray.
Okay.
And rest of the routine blood investigations like CBC, electrolytes, and and an ABG. Because
anything you'd like to do which might help in diagnosing better or monitoring better?
I would like to do a trans thoracic echo.
Okay.
And a lung ultrasound as well, to rule out any consolidation, the infective causes.
Okay.
The echo would tell me about the mechanical complications and the tamponade if at all there.
Okay.
So
always in an exam, whenever the question like this comes, you're going to tell about advanced cardiac output monitoring. Okay. Invariably, any ERDS or anything which gets complicated, you're going to say advanced cardiac output monitoring.
Okay. Yes.
Okay. So And repeat CPKMB because you repeat CKMB
Stent thrombosis.
because it's a you are suspecting if a stent thrombosis is there. If you are suspecting a repeat MI, you're going to do the evaluate.
CP. Yes, sir.
Okay.
Yes.
So the pulmonary catheter was inserted. This
Okay.
what is the interpretation of this? Just a disclaimer here. You to be frank, even I don't use PAC at a routine practice. I have given this as a scenario because it has come in the exam. As simple as that. Even if you don't know, you need to learn it for the exam. This mitral regurgitation, VSD, free wall rupture, all three scenarios have come in the exam. Please make sure that you read it for the exam. Okay. Do you know how to interpret this, Soumya? It's a pulmonary occlusion pressure. Okay. It is not a RVSP or pulmonary. It's a occlusion pressure. Can you interpret it?
I can see that V wave is
Here actually because I got it from up to date. It was marked already. It might be easy for you.
okay,
For
sir.
exam purpose, I don't know.
Because I can see the V wave is prolonged. It is tall, so I can think of a regurgitation. So tricuspid regurgitation.
Yes. Since it's a pulmonary
And
occlusion pressure, we're telling specifically, it will be from the left side. Left side is mitral
so
regurgitation.
mitral regurgitation, yes, sir.
Okay.
So,
And one more thing is you have to comment is pulmonary pressures are also high. Occlusion pressure is high.
yes, sir.
So this is suggestive of MR. Okay. This exact question has come in the exam. Okay.
Okay, sir.
Okay. So 1 minute. So echo showed EF of 30%, severe MR, patient continues to have hypertension even on noradrenaline of 3 mg per kg per minute. Pulmonary catheter was inserted, showed cardiac index of 2, PSP of 50, along with the POP tracing as shown before. JVP is 14, CKMB is elevated. What's your next approach?
With this value, it looks like patient is in cardiogenic shock. So I would like to, he's already on a noradrenaline. I would like to add second vasopressor.
Vasopressor.
I know dilator or an inotrope. I would like to say because he has a severe LV dysfunction. So I would like to consider dobutamine in him. And also I would like to I will inform the cardiologist of the same because CKMB is elevated and he's in acute heart failure as well. Cardiology and a CTVS team will be informed, and would like to consider a IABP in him. And I would like to repeat an ABG to look at the end organ perfusion.
Okay. So in this expected answers, sir, you're going to say that as you told, multi-site team opinion, okay, interventional cardiology and CTS opinion was taken. You'll add diuretics, you'll continue lung protective ventilation, add inodilator or the abdomen or milrinol. IBP was inserted. If patient continues to be in shock, you can say the plus or minus ECMO.
ECMO, yes.
Okay. It was decided to take up for surgery and do surgical repair along with CABG. Intra-op was uneventful. Patient was shifted to the ICU. Over next 2 to 3 days, patient condition improved and patient was gradually weaned off vasoactive drugs. Post-op day 4 of mitral valve repair, patient persists to have high drain output, more than 1000 ml per day. What is the cause of high drain output in this patient?
Maybe a bleeding.
Yes.
Any infection.
Okay.
A volume overload with the pleural effusion.
Okay.
And chylothorax. Okay.
I think we might have discussed about this. So you told in exam it's not easy. Okay. In fact, I had got a scenario similar to this where I couldn't diagnose, but then they'll see missing 1 point will not affect you because it is all about differential and approach to exam. You may lose 1 marks out of 4 or 5 marks. So it is not going to change your overall outcome in the exam. It's all about the approach. Okay. Yes. Further workup of drain showed high triglyceride indicating chylothorax. Okay, how will you manage this patient?
First, I would medical management and the surgical management would be ideal for him. So the medically, I would like to restrict. I would like to consider diuretics. Second, I would like to consider low fat diet with low fat diet, and would like to consider a somatostatin analog infusion like octreotide. And surgically, I would like to inform cardiothoracic team may do a pleurodesis or a ligation of the thoracic duct.
So, yeah, you are more or less covered everything. So, you're going to initiate a low-fat diet, then octreotide, then surgical as well as intervention radiology opinion you mentioned. Because intervention radiology also can do embolization of that thoracic duct.
Okay. Yes.
Okay. So, this patient continue to have a low GCS throughout the course. How will you approach this patient now?
Since he's a post-cardiac arrest patient, I would like to consider a hypoxic brain damage. So if it's beyond 72 hours, I would like to do a MRI brain. Before that, would like to do an EEG to rule out other causes of encephalopathy like a non-convulsive status epilepticus and other metabolic causes like hypoglycemia, hyponatremia, hypercapnia. All those to be ruled out, and then I would like to do an MRI brain to rule out a hypoxic brain damage.
Okay. So as we discussed before, it's all about the approach, and this also will come in either one of the scenarios. Definitely approach to patient with low consciousness, as you rightly told. Imaging either CT, MRI after 3 days, electrolytes, EEG to rule out seizures. Then that mnemonic of terms. Last time also I told you toxins, organ failure, metabolic, electrolytes, and seizures. Okay,
yes.
This is how you are going to approach in the exam. Okay,
yes.
Then they'll tell you what exactly is the reason. Okay, in this patient, inwardly they can build up to again communication or hypoxic brain damage or something like that. Okay, this is about the case per se. Okay, so regarding there are a lot of other questions they might ask in the exam. Just to brush to what they might cover is as I told you, the pulmonary catheter, ventricular septal rupture, they might give, and free wall rupture with a tamponade they'll give. So generally, in ventricular septal rupture, what they mention is they mention regarding the step up of oxygenation from RV to PA. Okay.
Yes.
Okay. Then in case of free wall rupture, equalization of diastolic pressures.
Okay. Yes, sir.
Okay. These are two things invariably they'll be in the exam. So complications of ACS, everything they can ask. Sorry, all the complications in one or the other way it will come.
Yes.
Okay. So regarding DAPT, I think you're aware of the new guidelines and all.
Yes.
Okay. So main thing is DAPT, invariably it will be aspirin plus ticagrelor in case of ACS with post-stenting.
Yes.
Okay. We don't use clopidogrel. Clopidogrel is used in very few scenarios. When we are using, especially when we are using a triple therapy, where aspirin and oral anticoagulation, we are using both. Okay. Then next few things just I want to say was you need to know about the timing, about primary PCI, what it is, what is rescue PCI. Okay. Then I think some scoring systems. I don't think it will be asked in the exam. Scoring system, bleeding stratification.
And precisely.
Then role of this thing they might ask you, role of tirofiban in the management. In non-STEMI, mainly in case of ongoing chest pain, whereas during STEMI, it's mainly when they have a low blood flow or poor blood flow, even after stenting. Okay. Modified ECG, V7 to V, especially to cover posterior, and right side ECGs, that is V3R, V4R, to look at the right ventricular MI. I think you know about Garbosa criteria. I'll not go into that. Then you know that the change in the nomenclature, right? STEMI is now been called as
Occlusive MI
Yes,
to
occlusive MI.
include the STEMI equivalents.
Yes. What are the STEMI equivalents you are aware of?
This Deventus, the Valens, and posterior STEMI hyperactivity.
Okay. So you should be aware of STEMI mimickers.
Yes.
Okay, I'll not go into that list. Okay, that's it. I think. Anything else you want to ask, Soumya?
Sir, I think this hypothermia and the ACLS, I have to go through.
Yes, because hypothermia is not a common scenario for us. That's why we don't read much.
Yes.
But in the exams, EDIC exam, it has come for me only in the exam. Okay. It has long work, but it can still come in the exam.
Yes, sir.
Okay. Thank you. If possible, next session we'll try to do 2 sessions, 2 short cases. Okay.
Yes, sir.
Okay. Anybody have any questions?
Tissue paper.
Recording, hopefully, I think by the end of the week, we'll try to share the recordings in the group. Okay. Okay. Thank you.
Thank you, sir.